Okay, hi, my name is Alisa Mendive. I'll be the FNP student for today. Today I'm going to be doing a musculoskeletal assessment on my patient of the day. May I have your name and your date of birth?
My name is Daniel Dooley and date of birth is 06/13/1991.
Perfect. So I'm going to go ahead and wash my hands, put on some gloves. Okay, I'm going to be doing a musculoskeletal assessment on you today. I'm first going to start off with the inspection and the palpation of the TMJ joint, temporomandibular joint. I'm going to ask the patient to open his mouth and close. Open. So I'm looking for any deflection or deviation. So now I'm going to go ahead and palpate for any clicking of the jaw, and that would be an indication of a joint dysfunction to the TMJ. Okay, go ahead and open, close. Did you feel any pain? So now I'm going to go ahead and inspect the temporalis and the masseter, and I'm going to go ahead and palpate as well for any tenderness or pain. Any tenderness, go ahead and clench for me. Clench your teeth. Clench. Good. Any pain or tenderness?
No.
Any pain or tenderness?
Mm-mm.
Perfect. So there is no abnormalities noted to the TMJ joint. From there, I'm going to go ahead and go onto the hands and the wrist. I'm going to go ahead and inspect the hands. I'm going to start off with the right arm. I'm looking for any masses, nodules, or gross deformities. Okay. And it can be an indicative of rheumatoid arthritis or osteoarthritis. I'm going to go ahead and palpate from distal to proximal, each joint, each finger. Any pain or tenderness?
No.
Good. And I'm going to go ahead and as well palpate the ulna and the radius. Any pain or tenderness?
No.
Okay, so no pain or tenderness noted. Now we're going to move on to the range of motion. I'm going to ask the patient to go ahead and extension of the hand. Good. Flexion of the hand. Perfect. Now go back to medial. Now I'm going to ask him to abduct his fingers. So abduction means away from the body. Open, and then adduction together. Close your fingers. Very good. Now I'm going to ask him to move his wrist. Abduction again is away from the body, so we're going to move this way. Very good. Now adduction. Very good. So I'm going to do this in no abnormalities noted, no pain or tenderness.
No.
Very good. Now, since I'm here on this hand, I'm going to do a couple of tests on this hand. I'm going to ask the patient to spread his thumb. Very good. And I'm going to ask him, I'm going to move the thumb laterally so that I can go ahead and assess the bridge here. It'll be right there. This is called the snuff puff test. So I'm going to be palpating here. And if he feels any pain, that can be an indication of a navicular fracture. Do you have any pain?
Mm-hmm.
Very good. Now I'm going to go ahead and do another test for carpal tunnel syndrome. I'm going to ask the patient to go ahead and flex the wrist. Good. Now I'm gonna go ahead and percuss just right here between the ulna and the radius. Do you feel any tingling or numbness? Very good. So there's no indication of carpal tunnel syndrome. I'm gonna go to the other side to do the exact same thing that I did on this hand to assess for symmetry. Okay, same thing. I'm gonna inspect the hand for any masses, nodules. Okay, very good. I'm going to palpate each finger as well from distal to proximal. Go ahead and swim. Good. Good. So now I'm going to ask the patient, now we're going to do the range of motion on this hand. Go ahead and again, extension, flexion, abduction, adduction. Now fingers abduction and adduction. Very good. Any pain or tenderness felt?
No.
I'm going to go ahead and do the snuff puff test on this hand as well. Go ahead and just move your thumb laterally. Any pain or tenderness?
No.
Very good. And I'm going to do the same thing for the carpal tunnel test. I'm going to ask the patient to do what we did on the other side and percuss. Any numbness or tingling?
No.
So now I'm going to move on to the Fallon's test. So I'm going to ask the patient to put his hands in a prayer position, and you're going to turn them downwards. So it's like a downward prayer. So you're going to go like this. Very good. And you're going to put force. I'm going to ask the patient to put force on the wrist for 30 seconds. Do you feel any pain or tingliness or numbness?
Slightly.
Okay, so it could be an indicative of carpal tunnel syndrome. Okay, go ahead. Since that was a positive sign, then I would move into the medium compression exam to both joints, to the carpal tunnel. So I'm going to ask the patient to, yes. And I'm going to compress this area in between the ulna and the radius for 30 seconds. Did you feel any numbness or tingling downward?
No.
No? Same thing to the other hand, compression for 30 seconds. Did you feel any pain or numbness or tingling to the median nerve distribution?
Yes.
Okay, so it could be an indicative of carpal tunnel syndrome. So now that we assess the wrist for inspection, palpation, and range of motion, I'm going to move on to the elbow. So I'm going to be inspecting the lateral and the medial side of the elbow for any gross deformities, warmth, swelling, any signs of inflammation. I'm going to go ahead and palpate the lateral and the medial epicondyle. Do you feel any pain or tenderness on your elbow?
No.
Okay, good. Okay. Sometimes if there is tenderness or pain felt, it could be a tennis elbow, it could be epicondylitis. So very good. Now I'm going to ask the patient to do the range of motion on this side. I'm going to ask the patient to flexion and extension, pronation, supination. Any pain or tenderness?
No.
Very good. I'm going to go, what I did on this side, I'm going to do the exact same thing on the opposite. Inspection for any masses, nodules, swelling. I'm going to go ahead and palpate the lateral and the medial epicondyle. Any pain or tenderness?
No.
Same thing, range of motion on this side. I'm going to go ahead and flexion and extension, pronation, and supination. Very good. So no abnormalities noted. So from here, I'm going to move on to the shoulders. I'm going to inspect the shoulders. If I see a shoulder lower than the other, it can be a sign of a dislocation of the shoulder. It's symmetrical, so there's no sign of a dislocation to the shoulders. So now I'm going to go ahead and palpate. I would start from the substernal notch and work my way up laterally, up the clavicle to the omicron process, which is at the tip of the shoulder. Okay, just medial of the omicron process is the ACG joint. Do you feel any tenderness or pain?
No.
Good. Now I'm going to go to the other side. Any pain or tenderness?
No.
Very good. So now I'm gonna do the range of motion on the shoulder. I'm gonna ask the patient to, you're gonna start off with flexion. You're gonna raise up your hand. And then you're gonna go extension, but it's gonna be hyperextension all the way to the back. Very good. Any pain or tenderness?
No.
Very good. Okay, you can bring it up. From here, I'm gonna ask the patient to do abduction of the shoulder, which is raising up overhead. Very good. Okay, put it down. And I'm gonna ask the patient to do adduction, which is, this would be a test for, it's called the cross arm over test. I'd ask the patient to cross over. Do you feel any pain or tenderness? So the cross arm over test, if there is a positive pain or tenderness, it can be positive for a rotator cuff injury. Very good. So now I'm going to do the exact same thing on the other side. I would ask the patient to flexion and then hyperextension. Now abduction overhead. Okay, bring it down. And then cross arm over test. Do you feel any pain or tenderness? Good. Very good. Now you can put your hands down, your arms down, sorry. From here, I can do another test, which is called the Nears test, where I would stand behind the patient and hold on his scapula. Go ahead and move forward. So what you're gonna do is you're gonna bring up your arm while rotating it laterally. Do you have any pain?
No.
Okay, good. So if there were to be any pain or tenderness, it could also be a rotator cuff injury or an impingement of the rotator cuff. I'm going to do the exact same thing over here, the Nears test. Hold down on the scapula, raise up while I'm rotating, pronating the arm. Very good. Any pain?
No.
Very good. So I did those two exams for the shoulder. From here, I would move on to the cervical spine. I would start off with the neck. So I would look at the neck for just inspect for symmetry. It looks good. I can also check the trachea. It's midline. And I'm also looking for any masses or nodules in the neck, any gross deformities. So from here, I would go ahead and just palpate. Do you feel any pain?
Mm-hmm.
Good. And I'm palpating the C7, which right now I will show when he's standing up to assess his spine. So I would ask the patient, I'm going to do the range of motions. Okay, so you're going to look up at the ceiling. That's extension. And then you're going to do chin to chest. Chin to chest, yes. That's flexion. Okay, perfect. You can lift up. Okay, and now we're going to do a cervical rotation. Just look to the right. Good. Now look to the left. Very good. Now I'm going to ask the patient to do right ear to shoulder. Very good. No, you bring your ear to your shoulder. Yeah, very good. And then the other side. So that was lateral bending. Do you feel any pain or tenderness?
No.
Very good. So now I would ask the patient to stand up because I'm going to go ahead and assess the spine now. Go ahead and stand up for me. Okay. So I would start off at the C7. I would first inspect the spine. I would go ahead and check the posture and the shape of the spine. He should have it's like a concave and then slightly curved at the bottom. I would go ahead and palpate the spine, placing one finger and the vertebra down, just to see if there's any like masses that can indicate a tumor. Do you have any pain?
No.
Okay. Very good. Okay, and I would also palpate the muscles on this side. Any pain? Very good. So now I would do the range of motion on the spine. So I would ask the patient to bend forward. This is flexion. Try to touch your toes. And while he's touching his toes, I can go ahead and look at the alignment of the spine to see if it's aligned, if there's no abnormality noted. I would also look at his shoulders because the shoulders can also mean a dislocation. Okay, you can go ahead and stand up. Oh wait, just go back down. While I'm here, I would go ahead and inspect the hips. I would palpate the hips to see if there's any limb length abnormality, like if one limb is longer than the other. So it's good. No pain, no tenderness on your hips?
No.
Okay, you can go ahead and stand up. Now I would ask the patient to extend backwards. Very good. Any pain or tenderness?
No.
Now I would ask the patient to rotate to the right. Any pain or tenderness?
No.
Okay, now I would ask the patient to turn to the left.
No.
Very good. And now I would ask the patient to, this would be the lateral bending, to reach towards the left side. Any pain or tenderness?
No.
Now this side.
No.
Very good. You can go ahead and sit down again. Oh, we can stand up, sorry. While the patient is standing up, I would also just inspect the overall posture, right? Okay, so from here we're gonna go ahead and assess the hips. I would ask the patient to lay down. Okay, so resuming back to the assessment, I would now have the patient laying down to inspect the hips, palpate the hips, and then do the range of motion on the hips. So I inspected the hips when he was standing up. There was no abnormalities noted. So now I'm going to go ahead and palpate the iliac spine, the anterior. I'm going to start off with the left. Any pain? No. No crepitus noted, no pain. I'm going to ask the patient to lift up his leg towards the ceiling. Very good. Drop. Now I'm going to ask him to lay down on his stomach. Same thing. Ask him to lift up. This is extension of the left hip. Very good. Now lay down and lay on your, turn to the side, this side. Very good. Now to test for abduction, pick up the leg. Very good. Now I'm going to ask him to lay a little bit, go back to the front. And I'm going to ask him for adduction of the leg. It would be going inwards. Any pain? No. Very good. Now I would do internal and external rotation of the hip. I would flex the patient's knee. Internal and external. Very good. Now we're going to do the right hip. Same thing. I'm going to go ahead and palpate the iliac spine. No pain? No. Okay, go ahead and lift up your left leg towards the ceiling. Very good. Down. Right leg, sorry. And then get on your stomach. Again. Lift up towards the ceiling for extension. Very good. Down. Now you're going to get on your left side. Now we're going to do abduction. So lift up your right leg. Very good. Down. And then back up to your back. And then adduction, we're going to cross it towards inwards towards the medial line. Now we're going to do internal and external of the right hip. External, internal. Very good. Now I'm going to ask a test that I could do if the patient's coming in with pain to the back radiating to the legs would be the straight leg test. I would ask the patient to lift up his leg, and if he feels any pain, numbness, below 45-degree angle, then it would be a positive sign for a sciatic nerve or a herniated disc that we need to further examine. Go ahead and lift up the right leg. Any pain?
No.
Very good. Okay, so there was no abnormalities noted to the hip. So from here, I'm gonna do a test for. Well, I'm gonna move on to the knees. I'm gonna be inspecting the knees, and while I have him laying down, I can do some tests for a PCL tear or an ACL tear. So I would do on both legs. I would ask the patient to flex their knee. Very good. And I would sit on the foot to provide stabilization. I would grab behind in the fossa area behind the knee, and grab right on the side of the tibia and the fibula. And while I'm pushing back from the fossa, I would push towards, so this would be the anterior drawer sign. And if I see something, if he feels discomfort or pain, then it could be a sign of a meniscal, a PCL tear. Does it hurt?
No.
Good. And I would do the exact same thing. While I'm here, I would the posterior. That was the anterior, and I would do the posterior. So it would be me pushing towards while I'm pushing back. Any pain?
No.
Okay. I would do the same thing to the other leg. Inwards. Out. Any pain?
No.
Okay. No abnormalities noted. So I would ask the patient now to sit up for me. So now I would move on to the knees. I would inspect the knees for any gross deformities, warmth, redness, inflammation, and I would go in and start palpating. So I would palpate the medial and the lateral epicondyle of the femur, and then the lateral and the medial of the tibia fibula. And then just on the side is the meniscal groove, and here's the patellar. So I would just palpate there for any pain or tenderness.
No.
Good. And I would also palpate behind the fossa, and if there were to be like an infusion, then it would be Baker's cyst. And now that we're on this right side of the knee, I would ask him to perform the range of motion test. So extension, flexion, and then inwards, internal, and then external. So now I would move on to the other leg, same thing. Palpating, inspecting for any gross deformities. I'm going to do the exact same thing that I did on the other side now to this one. Palpating. Okay, now go ahead and lift up your leg, extension, and then flexion, and then inversion, and then external. Very good. Then from there, I would move on to the feet. Move on to the feet. I would inspect the toes, also inspect the side, the medials, and then I would palpate the medials, and then I would also palpate the heel bone, just inspect it for any deformities, any pain. Also assess while I'm here, like for any gout, and then I would ask the patient to extension, and then flexion, and then to this and then I would ask the patient to towards in inversion and then external, and then the same thing, inspection and then palpation, and then extension, flexion, inversion, and external. Okay, this concludes my musculoskeletal exam, and thank you for watching.